You know, we have this fundamental assumption about human skin. We just assume it has this infinite capacity to reset itself.
Right, yeah. The baseline expectation is always resilience.
Exactly. You get a rash, you apply some sort of cream, the inflammation goes away, and the tissue just, well, reverts to its factory settings. We are totally wired to view skin issues as temporary.
We really are. We assume the epidermis will just rebuild itself exactly the way it was before.
But occasionally, you encounter a condition that completely shatters that assumption. Something that doesn't just, sit on the surface, but acts more like a slow-moving earthquake.
Oh, absolutely.
It fundamentally and permanently alters the actual landscape of the human body. And when that landscape belongs to a developing child, the stakes are staggering.
Welcome to today's deep dive. We are thrilled you're joining us.
It's an incredibly important topic.
Our mission today is to understand the profound, long-term structural implications of delayed diagnosis in pediatric lichen sclerosus, or LS.
And we have some really solid sources to guide us today. We do. We're looking at clinical guidelines from the British Association of Dermatologists, studies from the Journal of Pediatric Urology, and insights from a bunch of pediatric and dermatological societies.
The medical literature paints a very stark picture here. LS frequently gets brushed off as a minor irritation, but the reality is, without intervention, the inflammation can literally erase normal anatomy.
Okay, let's unpack this. Because before we look at the structural damage itself, we have to look at the timeline. The damage requires a runway, right?
It does, and the data shows the average delay in diagnosing pediatric LS is anywhere from 1 to 1.6 years.
Wow. That is a massive window for a chronic condition to just operate completely unchecked, especially on such incredibly delicate tissue.
It's a dangerous delay, and it seems to happen because pediatric LS is essentially a master of disguise.
Yeah, reading the sources, it's basically a medical chameleon.
That's a perfect way to describe it. In young girls, who make up the vast majority of these cases, the hallmark signs are intense inflammation leading to purpura, which is bruising, and fissures.
And when a child is brought in with severe genital bruising and tearing, the immediate protocol for any doctor is to suspect sexual abuse.
Right, they have to. Which creates this agonizing paradox for the family.
It must be terrifying. The medical system is doing what it's supposed to do, protecting the child, but it initiates a deeply traumatic investigation for the parents.
Exactly. They just want help for a skin issue, and suddenly they are plunged into an abuse inquiry. The diagnostic momentum for the actual disease completely stalls.
And even when abuse is ruled out, the disguises just keep coming, right?
Oh, yeah. The intense nighttime itching often leads to a quick, incorrect diagnosis of pinworms. Or the white patches are mistaken for a stubborn thrush infection.
Or they just blame poor hygiene.
Yes. The doctor tells the parents to just use more soap.
I have to jump in on that because wouldn't aggressively scrubbing that compromised tissue with harsh soaks just destroy whatever is left of the skin barrier?
Yeah. It accelerates the damage exponentially. The barrier is already failing. And alkaline soaps strip away the natural lipids, which just intensifies the micro tears.
Right. It's like throwing gasoline on a fire.
Yeah.
But the disguise that really stopped me in my tracks was constipation.
It's a bizarre presentation, but very common.
A localized skin condition presenting as a GI issue. Walk us through how that even works.
So it's a textbook example of a pain avoidance cycle. LS frequently affects the perianal skin in a classic figure-of-8 pattern around the vulva and anus.
And the tissue gets tight and starts fissuring.
Exactly. So when the child attempts to have a bowel movement, the mechanical stretching causes sharp tearing pain. The child naturally associates going to the bathroom with severe trauma.
So they just actively withhold their stool.
They hold it in for days. The stool remains in the colon, water gets absorbed, and it gets larger and harder.
Oh, making it even worse when they finally have to go.
Precisely. By the time they absolutely have to pass it, the trauma to the tissue is massive. The parents see the child agonizing, so they take them to a gastroenterologist.
And they get prescribed laxatives or GI testing.
While the actual root cause, the skin tearing, remains completely invisible to the GI doctor.
So for a year and a half, this child is enduring pinworm treatments, GI workups, or an abuse investigation. And all the while, the biological clock is ticking. Which brings us to the structural fallout. Let's look at female anatomy first.
What's fascinating here is the specific cellular mechanism driving the destruction.
Because it's not a virus or a bacteria, right?
No, it is a lymphocyte-mediated process. Your own immune cells are basically attacking the basal layer of your epidermis.
Wait, so your own body is causing the damage?
Exactly. This chronic inflammation triggers fibroblasts deep in the skin to overproduce abnormal collagen. That creates dense, rigid scar tissue. Over months and years, it causes the vulvar architecture to undergo resorption.
Resorption, meaning the labia minora actually begin to shrink and flatten out.
They don't just shrink, they are progressively obliterated. The constant sparring causes the labia minora to fuse with the labia majora until they just cease to exist as separate structures.
This really is a slow-moving architectural collapse. You literally have distinct physical features melting and fusing together.
It's devastating.
But surely the body can regenerate, right? I mean, if someone finally gets diagnosed after 18 months and the inflammation stops, can the tissue reverse that collapse?
It cannot, and that is the most difficult reality of this condition. Normal wound healing replaces damaged cells with functional tissue, but LS replaces it with sclerotic bands of collagen.
So it's permanent.
Yes. Once the labia have resorbed, that architecture is permanently lost. No cream can regenerate it. It requires highly specialized reconstructive surgery.
And the collapse goes beyond just the labia. The clinical data mentions clitoral phimosis. That sounds incredibly severe.
It is a severe progression. The inflammation targets the prepuce, causing the skin to thicken and scar. Over that diagnostic delay, it can completely fuse.
Meaning it buries the anatomy under a rigid plate of scar tissue.
Exactly. Completely burying the clitoris.
Which, that traps dead skin cells and secretions underneath, right? Forming smegmatic pseudocysts.
Yes, and those pseudocysts are incredibly painful. They create localized pressure pockets that get infected easily. Plus, the scarring progresses downward, causing introital stenosis.
That's a narrowing of the vaginal opening.
A severe narrowing. The rigid collagen bands act like a purse string, drawing the tissue tightly together and destroying all its natural elasticity.
So the stakes of that delay just went from a persistent itch to requiring lifelong structural management or surgery.
It's a huge escalation.
Now, the inflammatory mechanism doesn't discriminate by gender, even though it's way more common in females.
Right.
When this happens to male anatomy, the structural fallout is just as severe, but it manifests as a completely different, like, mechanical failure.
Right. In boys, LS almost exclusively impacts those who are uncircumcised. It's actually the leading cause of acquired phimosis in this demographic.
I have to pause there. If it mostly affects uncircumcised boys, isn't the foreskin itself the root cause? Like, is it just trapping moisture and causing bad hygiene?
It's a logical assumption, but the etiology is much more complex. The foreskin creates a specific microenvironment. Microtrauma combined with trapped urine, which acts as an irritant, triggers that same autoimmune response we see in girls.
Oh, I see. So the foreskin tissue becomes sclerotic.
Yes, forming a thick, unyielding white ring that makes retraction impossible. That's the acquired phimosis.
But if left unchecked for a year and a half, it doesn't just stay there. It migrates inward.
The scarring advances proximally, targeting the metatis, the urethral opening causing metal stenosis. The robust inflammation replaces elastic tissue with rigid collagen, narrowing the opening.
The data said sometimes this opening constricts to less than 2 millimeters.
2 millimeters?
It's incredibly tight.
That is barely the width of the ink tube inside a ballpoint pen. And it gets worse. The stricture can travel even deeper into the urethra to cause panurethral strictures. The entire distal urinary tract begins to calcify and narrow.
It sounds exactly like a plumbing system slowly calcifying from the outside in. And the implications of that are terrifying. The sources document cases where this leads to complete renal failure.
If we connect this to the bigger picture of human hydrodynamics, the mechanism makes terrifying sense.
Wait, renal failure from a skin condition? How does a surface-level skin blockage travel upstream to threaten the kidneys?
The urinary system requires low pressure to function safely. But when you introduce a 2 millimeter stricture at the exit, you create an immense outflow obstruction.
So the bladder has to work overtime just to force fluid through that tiny opening.
Exactly. You read accounts of boys whose foreskins literally balloon up with trapped urine every time they void.
Oh, wow. That sounds awful.
The constant high-pressure voiding causes the bladder muscle wall to thicken dramatically. Eventually, this overwhelming back pressure overcomes the vesicoreteral valves.
Those are the delicate one-way valves that stop urine from flowing backward, right?
Yes. When those fail, high-pressure, potentially infected urine refluxes all the way up into the kidneys.
Which physically crushes the nephrons, the actual filtering unit.
It destroys the renal parenchyma, so a delay in diagnosing a localized autoimmune skin condition ultimately orchestrates a mechanical failure that destroys the child's kidneys.
That completely elevates LS from a dermatological issue to a systemic, life-threatening emergency.
It truly does.
So we have established this irreversible, devastating anatomical damage in both sexes. The vanishing architecture in girls, the catastrophic hydrodynamic failure in boys. But children with these structural changes, they grow up.
They do, and they carry this altered anatomy into adulthood.
And that transition exposes one of the most persistent and frankly dangerous myths in dermatology.
The belief in spontaneous pubertal remission.
Yeah, for decades it was just accepted medical consensus that pediatric LS would cure itself once a child hit puberty. Why did doctors believe that? What was the biological rationale?
It was basically an observational error based on hormones. When a young girl enters puberty, the sudden influx of estrogen naturally thickens and matures the vulvar epithelium.
So the hormonal thickening just masks the visible signs of LS.
Exactly. The angry redness fades, the skin looks more robust, and the symptoms might temporarily quiet down. So physicians told parents, well, great news, she's grown out of it.
So the old comforting belief that a child will just grow out of it at puberty is not just wrong, it's actually a dangerous myth that prevents proper lifelong care.
It is deeply dangerous. The underlying autoimmune fire is still burning in the deeper dermis. Landmark prospective studies like the Smith and Fisher data from 2009 shattered this myth entirely.
They track these pediatric patients through puberty.
Yes, and they found that the disease frequently persists or it goes latent and reactivates with incredible aggression in young adulthood.
And the danger is that young women, believing they are cured, abandon all maintenance therapy. They stop seeing specialists. What are the long-term functional implications of carrying that untreated childhood scarring into their 20s and 30s?
The psychological and functional burdens are profound. Women who suffered from clitoral burying and introital stenosis in childhood are left with severe dyspareunia, which is intense pain during intercourse.
Because of the strictures.
Right. Furthermore, the entrapment of the clitoris in dense scar tissue frequently leads to anorgasmia. You have a condition misdiagnosed as thrush at age 7, now dismantling a patient's intimate relationships at age 27.
And beyond the mechanics, there is a very real oncological threat here, too. The data links childhood onset LS to a heightened risk of squamous cell carcinoma, or SCC, in adulthood.
This is the most critical long-term variable. SCC is virtually non-existent in prepubertal patients. But carrying an LS diagnosis into adulthood carries roughly a 4 to 6.7% lifetime risk of developing cancer directly on those lesions.
Let's drill down on the biology there. How does an autoimmune skin response translate into malignancy?
It comes down to cellular turnover. Chronic inflammation means the tissue is constantly being damaged and constantly rushing to repair itself.
So when cells are forced to divide and replicate at that hyperactive rate for decades, the probability of errors skyrockets.
Precisely. The DNA essentially gets sloppy because it's rushing to rebuild the tissue, and the local immune system is also dysregulated, so it fails to destroy mutated cells before they turn into a carcinoma.
So what does this all mean for intervention? The clinical guidelines are absolute on using ultrapotent topical corticosteroids, specifically clobetasol propionate.
They are the gold standard.
But I have to push back here. One of the universally known side effects of applying potent steroids to the skin is atrophy, right? Thinning of the
This
tissue.
is the standard concern, yes.
If we are dealing with skin that is already compromised and tearing, aren't we risking further destruction by applying a drug known to thin the skin?
It is incredibly counterintuitive, but the immunology explains it. In healthy skin, long-term clobetasol absolutely causes atrophy, but LS skin is entirely different.
Oh, how so?
The intense localized immune response makes the tissue paradoxically resistant to steroid-induced thinning while the disease is active. The clobetasol aggressively suppresses the cytokine cascade locally.
Ah, so you have to extinguish the fire before you can worry about water damage.
Exactly. And the data is unequivocal. The risk of allowing the architectural collapse and the cancer pathway to continue far outweighs the risk of steroid atrophy.
That makes total sense.
Plus, once the acute inflammation is controlled, the guidelines mandate long-term, proactive maintenance therapy, applying it once or twice a week for life.
You aren't just treating flares, you are suppressing the subclinical inflammation to protect the anatomy and mitigate that cancer risk.
Precisely.
So to synthesize this for everyone listening today, pediatric LS is a ticking clock. A delayed diagnosis provides the time needed to permanently erase normal anatomy.
It alters the body's actual structure.
It can systematically destroy the urinary tract, leading to renal failure. It leaves patients with lifelong physical and psychological burdens.
It's a huge burden to carry.
If you are in a position to advocate for a child's health, this knowledge is paramount. Persistent unexplained symptoms demand expert eyes, not just a passing assumption about hygiene or a quick prescription for laxatives.
Absolutely. And as we step back and look at the broader implications, there is one final lingering thread in the data that is truly fascinating.
What's that?
The literature consistently points to a strong genetic component in LS. It's heavily associated with a specific genetic marker, HLA-DQ7, and we observe familial clustering.
Wait, so it runs in families?
Yes,
Oh, wow.
approximately 10% of patients have affected relatives, which forces us to ask a really compelling question.
Okay.
If a young child is finally correctly diagnosed after years of delay, what does that mean for the generations that came before them?
Oh, wow.
Right. Could that child's delayed diagnosis actually be the key to uncovering the silent, anatomically altering symptoms that their mother, their aunt, or their older sister have been secretly enduring for decades?
Just completely unaware that their pain actually has a name.
Exactly.
It reframes the entire mission. Getting that early diagnosis right doesn't just halt the architectural collapse for one child.
No, it doesn't.
It has the potential to rescue the anatomy and the peace of mind of an entire generation of women in their family tree. A ticking clock that, once heard, can finally be stopped. Well, that is definitely something to think about. Thank you so much for joining us on this deep dive.
Thanks for having me. It was a great conversation.